In this video, I'm demonstrating partial knee replacement with a MAKO robotic system. You can see that medial osteoarthritis is very much there with the sclerotic tibial side, and alignment is good. So we decided to do MAKO partial knee replacement. We have just now collected the center of femoral head, that is a hip joint, and then we have collected the points. After that, we have to check the range of movements from the extension, 0 degree flexion, 45 degree flexion, 90 degree flexion, and further hyperflexion. You can see in the graph, just focus on the graph, the tightness is there all throughout the range of movements. The pink colored bar showing down, that means tight. Now we are tweaking the femoral and tibial components now, so that the bar on the graph shows up, that has become now blue color. That means it is showing 2 to 3 mm, 4 mm, depending on the squares, the looseness of the knee in 0 degree, 30, 45 degree, 90 degree, and hyperflexion of the knee. It is better to keep it 2 to 3 mm looser in all throughout the range of movements, because if you keep it tight, then it will be difficult for reduction, and also it is not physiologically for the partial knee replacement not good for the longevity of the implants. It is better to keep it loose, so that the person will be comfortable, and he will have feeling of the natural knee. After this, we have to mark the cartilage, where the we have to assess where the how much implant is proud over the cartilage. That means to say the implant should be about the 1 or 2 mm above the cartilage, should not be more, and should not have a gradient kind of thing. So with this, we are checking the cartilage mapping. Then we have to see overlapping. We have to give pressure and check how much pressure on axial loading this implant is having. You can see that this implant is taking into consideration of each and every aspect of the functional outcome, and also the implantation. This is the cartilage mapping around the tibia and the femoral component, and then axial loading, and how much tibial and femoral component overlaps, means to say the loading happens over the implant, not other places, and how much of the implant is over the overhanging, and sizing, balancing, everything. After that, we are now going in for resection. We are resecting the tibial side, then we will go for the posterior condylar resection, then we will be doing the burring of the femoral side. First, we have to cut the tibial side, then posterior condylar, and then burring. So we have to remove the green colored bone with the burr. Over that, it will also show us for the lug holes of the femur, and also lug holes for the tibia after the tibial bone is removed. The same thing after the femur tibial side, we will be removing the anterior, that is the vertically, first horizontally, then vertically. After we remove it, you can see that we have put the lug holes for the tibial side, and then we do remove any of the osteophytes obstructing posterior osteophytes and meniscus. Then we see the trialing. Then after that, we put the implant and check. You can see this is a trialing, how much flexion is possible, how much overlap of the femur and tibia, and what is the axis of movement, what is the tightness. In this, you can see we are checking again in the graph that about 2 to 3 mm of the implant, the joint space loosening we have kept in this case in 0, 45 degree, 90 degree, and hyperflexion. If you keep loose in the mid flexion, then hyperflexion will become. If you keep tight in the mid flexion, hyperflexion is difficult. So we keep little loose, so that hyperflexion also possible. If there is anything obstructing for the hyperflexion. In the initial phase of planning, we can give flexion of the femoral component and or extension of the femoral component. All this is possible so as to get the complete range of movements for the knee. Once it is done, then there is almost like a completion of procedure. Then we will have to go for the implantation. As lug holes are already made with the system, then we have to wash it, give the intra-articular infiltration, and then we are going for the implantation. So implantation is a straightforward procedure. We have to just put the cement and fix the tibial component and the femoral component and the insert. After implantation also we can check the knee range of movements and knee throughout the range of movement, how much gap is there and how much balanced. However, once we are committed to fix the implant in that position, these changes cannot be made afterwards. So these changes of the implant positioning, implant alignment, balancing, soft tissue tension throughout the range of movement, not just extension and flexion. Extension, 45-degree flexion, 90-degree flexion, and hyperflexion complete throughout the flexion, as we intend to get complete flexion whenever we are doing partial knee replacement. So whenever we are doing partial knee replacement, taking the help of MAKO robotic system is a very helpful. It will give accurate data so that the functional outcome is very good and we can expect excellent outcome. Thank you for watching this video.